Oh, yeah. Good afternoon. Guess what time it is? It is 4 o'clock in the mountains, which means 6 o'clock on the East Coast and three on the West, five in the Central, just so you know. And it is Fertility with Fink and Friends. I am Fink, and you are Friends, live from CNY Fertility in Colorado Springs. My name is Dr. Randy Fink, where I am the clinical director of IVF services here at this wonderful facility. And as always, on our Tuesday afternoon, this is the place to be. And I am so glad that you are able to join me here because this is the time that we get to sit down and hang out with our friends and talk about things that are important, talking about women's health, talking about fertility, talking about IVF, talking about treatment, talking about whatever it takes to make your life happy and what we can do to help get you there. So we've got a couple of different Instagram feeds. We've got my Instagram right here. Thanks to everybody for being there. And we've got CNY's Instagram here. We've got Facebook and YouTube and LinkedIn right here in the middle. And as always, it is wonderful to see all these folks first joining H Shoe, it looks like that is. You are number one. Hello to Sharmila. Thank you for being here. Angelina, as always, a pleasure. And Noodles for Life, Ruzik Blue from Las Vegas. Christina is here, the Freemans. We've got Sadie Ann. Good afternoon to Zinni in Miami. Michelle Marks, nice to see you also, as always. Hi to Shada. Nice to see you here. Let's see. Here's a question. Myo-inositol for women with PCOS. Should it be the D-Chiro blend? Well, no. Actually, I recommend it not be the D-Chiro blend. And so why is that? D-Chiro myo-inositol is not the same thing as myo-inositol. There is a commercially available blend that exists in a 40-to-1 ratio of D-Chiro myo-inositol to myo-inositol. The evidence is just much better on plain old simple myo-inositol, and it's 4 grams or 4,000 milligrams a day. And that would be 4,000 divided into 2, so 2,000 milligrams twice a day. I was just looking at the particular supplement that I recommend for it, and they're 500 milligram capsules, so you have to take 4 of them twice a day. It is a lot to take. That supplement ends up to be, I believe it's about $20 or so. Metformin is the same thing, and it's often a little cheaper because it's pharmaceutically manufactured, so we know what's in every pill, and insurance will often cover it. So I don't recommend even that commercially available one that is in that ratio of 40-to-1 D-Chiro to regular myo-inositol. That's a very good question. Thank you for asking it. Let's see who was our number one over here on the CNY side. Nick Betez, thank you for being here. Is that really Erica Bush who is here? I wonder if she's still on. It's nice to see you, Erica. Haven't seen you around for a while or heard from you. Hey to Sammy and Melanie Madrid, April Crump, Paola, Sweetia, Bushra, Liz Beffy, and Designs by Shauna. Yes, that is Erica Bush there. And you're going to be all thrilled that I said your name like twice in one broadcast. It's very good to hear from you, my old friend. Is that really Dee Polito? Is that the Donna Polito I know? Could be. Hi to Vic. Rosa asks, so while taking Orilissa before an FET, is there any test can confirm it's working effectively? No, we don't believe that you need to test for it. So what you're doing with Orilissa is trying to suppress endometriosis and its effect on the endometrium, on the uterine lining, before you do your embryo transfer. And we know that that inflammation is called BCL6. We can test for it, but testing it again, pardon me, after you've started treatment is not something that is currently recommended. So good question there. Blue and Mama, Haley Booms, Nick asks, need help. What are the statistics of a 3-day embryo versus a 5-day embryo? I have 14 day 3 embryos trying to decide if I should grow them out to day 5. We want 2 babies with these embryos. All right. Well, so really, Nick, the answer to that question has to do with how old you are when those embryos are created. So if you are 35 or younger, if we have day 5 blastocysts, a day 5 embryo that is untested, you haven't done PGT testing on them, then each of those embryos will give you about a 40% probability of getting you pregnant. All right. Now, in that same age group under 35, if we say, okay, let's make it a day 3 embryo, well, maybe we're cutting that number in half, maybe a little less. So I would say there's probably a 15 to 20% chance of a pregnancy with each day 3 embryo. If you have that many day 3 embryos, I personally think that means it's a lot of embryo transfers that you're going to have to do before you get to the first ones that are normal. And the goal is we'd like you to not have to do so many unsuccessful transfers. So that's potentially the benefit of growing them out to blast. Now, if you had 3 embryos, I might say, well, I wouldn't really want you to do that because it's really risking those embryos, right? Whereas, thawing a day 3 embryo, the success rate from thawing is about 97%. So we do very, very well with that. It's much better to thaw a day 3 and grow it to blast than it is to say, take a blastocyst, thaw it, do PGT testing, refreeze it, then when results come back, thaw it again. That gets to be a much harder sell. That's much harder on the embryos. But I think that, Nick, if you've got 14 day 3 embryos, let nature help you to determine which of those embryos is going to be more likely to get you pregnant. Grow them out to blast. You're going to lose, depends on your age, but you will lose some of them, and that is to be expected. But then at least the ones that remain are the ones that have a much higher probability of being able to get you pregnant. And that's my 2 cents worth there. Hello to all our friends on the Facebook side. Oh, Stardust Redbow is here, one of our favorite people, certainly with our favorite name, Stardust Redbow. You have the best. You get the best name of the day award. Stardust asks, is prednisone safer during pregnancy? Is there any risks in the difference of cleft palate? Well, so you wouldn't want, they're really kind of the same thing, prednisolone and prednisone. In the early pregnancy, we keep you on it, but we do taper you off of it. That's not something that you would need to stay on for the long term. Now, there are some people who do need to stay on it, people with things like adrenal insufficiency, people with, serious asthma may have to be maintained on oral steroids. But as far as embryo transfer goes, it's a short-term problem that you're on prednisone, and we would expect to be tapering you off. It's nice to see you, Red Stardust. I almost called you Red. You know what? When my son was little, we had his favorite little stuffed animal was named Red Bone. And so whenever I say your name, I always think of Red Bone the monkey. But you are Stardust. Carolyn says, hi, hello to Carolyn. I don't plan to transfer until November. When can I start to suppress the endometriosis? So we want you on 60 days of suppression for endometriosis prior to doing that transfer. 60 days of suppression. So if you're thinking about transferring in November, we are already here October the 1st. And so you want to start on your suppression right away. Michelle Stewart says, hi, Dr. Fink. I start STEMS next month. On my follow-up call last week, I was told that I wouldn't be prescribed prednisone due to being diabetic. That's the reason for prednisone. Is IVF still successful without it? Yeah. So the reason. So one of the things that oral steroids do is that they will raise your blood sugar, and we would much rather have your blood sugar being in good control than giving you prednisone, which is going to make your blood sugar kind of go all out of control. It is not critical for IVF or for embryo transfer. Oftentimes we use it because we're just trying to suppress some of the normal immune response. We do that here at CNY, but that is not a standard of care in most places. You will not be on prednisone in many other clinics. And so is it strictly speaking necessary? Well, we know it's important for some subgroup of people, but in the general population, especially in your case, if you've got diabetes, I would say that you probably are better off without that prednisone unless we come to find otherwise. Bloom Healthcare and Staffing. Hello, Blooms. I can't wait to meet you, Dr. Fink. I'm 45 with a low ovarian reserve. Before priming with estradiol and progesterone, I had 9 follicles. I primed for 3 weeks, and it showed last week I have 1 embryo measuring, I don't think you mean embryo, they're measuring 12.6 millimeters. And 2 days ago, the ultrasound showed I have no follicles at all. What should I do? And what chances do I have? So certainly being at 45, that does decrease our risks, or rather our outcomes for live birth with your eggs. There are many clinics that will not even do IVF at the age of 45 because the odds of success are so very low. So sometimes when you are on extended priming there with estrogen and progesterone, it can quiet down the ovaries. And that's actually not a bad thing, because usually then when you stop and you start on some stimulation, those follicles will start to grow, and they will grow in sync. So one of the things that we use that priming for is a synchronous growth of the follicles in the ovaries so that they grow at the same pace. So rather than having a couple of 12s, a 14, a 16, a 19, a 24, that they're all kind of growing about the same pace, and maybe they're all 16 or 17 at the same time, which is never really a possibility that they all will be, but at least that the majority of them will be. That's kind of the goal that we're after there. And Kristen says, I transferred 2 untested M babies yesterday, 1 for AA that fertilized before day 2, and 1 for BB. Hope we get a sticky baby. Yes, absolutely. And to Alyssa, I have active cysts delaying my retrieval cycle, even though I'm on Lupron. Estrogen is 279. Will 1 more week of Lupron resolve it and be able to move forward with stims and retrieval? So even though you're on Lupron, and Lupron is shutting down your hormones, that cyst is still secreting hormone. If your estrogen level is 279, that cyst thinks that you're about to probably ovulate. Now, it may be that your LH level and your progesterone don't think that you're about to ovulate, but that is a hormone secreting cyst. And so, yeah, we want to shut that down before you start your stimulation. So sometimes we do that with birth control. We can certainly do that with Lupron. And is 1 more week going to do it? Well, I mean, maybe. It may take another couple of weeks, but you are definitely better off stopping that, because that little cyst right there may stand in the way of the other eggs being able to grow. So yes, for sure, you want that to be taken care of. Let's see. Vic Escree over here on the CNY side says FET protocol recommended for a 42-year-old. Well, so we have 2 options there, Vic. We've got a medicated cycle, and we have a natural or a modified natural cycle. The old standby in IVF is to use a medicated cycle. The medicated cycle is where we are giving you the hormone in order to stop your ovary from producing hormones. We want to control all the hormones there, and that's what we have done in IVF since IVF was invented. And so there are really no variables involved with that, because we're controlling everything. Whereas in a natural cycle, we're letting your body come forward with the hormones so that you are at the forefront of making your own hormones. And that's really an ovulatory cycle. My personal preference in most cases is that an ovulatory cycle is just easier on your body. So that's often what I recommend. It means it is well understood that there are lower risks for certain pregnancy complications, specifically blood pressure complications with a natural cycle. There are some studies there, all the studies agree that medicated versus natural are at least equivalent, but there's some studies that show there's a little higher success rate with a natural or a modified natural cycle. So I would do a natural cycle if you're able to, or an ovulation induction cycle to make sure that you get a follicle that you then release. Some people's bodies don't want to cooperate with the natural cycles. And if that's the case, it's not a problem. Just do a medicated cycle. But which one is better? There is no one protocol there that says it's better for any particular age group. So really, ultimately, it becomes a preference. So I'd say either way is an okay way for you to go. Sharmila asked, how do you decide a modified FET or fully medicated? Well, Sharmila, I think we just sort of talked about that. How do you decide? It's really kind of a question of preference. So there's a fully natural cycle, which is where your body is making all the hormones, and it's based on you creating that follicle in your ovaries like you might every single other month. Oftentimes we'll add some ovulation induction to it. And so that's adding some letrozole. Letrozole will make sure that your ovary is going to produce an egg, that you're going to produce a follicle that will grow. I like to trigger those ovulations because then it puts a little more control into your hands over the logistics about when you're going to have that embryo transfer. But either one is okay. The biggest thing about a medicated cycle is that you have to do the progesterone and oil shot. That next to the HSG, so the hysterosalpingogram, the dye test, I think is our least popular test in all of the fertility world. The least popular treatment in all of the fertility world is that involving the progesterone and oil shot, because it's a big needle with a thick viscous fluid, that progesterone, and you have to give yourself a shot in the butt every single day until the time that your placenta takes over making the hormone, which is about at 10 weeks of pregnancy. So the placenta takes over at about 9 weeks, but we continue that until 10 weeks. So I think a natural cycle is a little better. We use some vaginal progesterone as a little extra support, but you don't have to do the PIO shot. Now, there are many of you out there who have done this, and you say, well, you know what, it wasn't really that bad. I mean, we can live with it. I mean, if there are a lot of painful decisions that have to be made in parenthood, and certainly in pregnancy as well, and that is probably one of them. But my feeling is life is too short to get shots in the butt if you can avoid it. And so therefore, I would say if you can do a natural cycle, seems to me to be a better bet. Shada asks, what do we do if the BCL6 or CD138 comes back positive? Okay, so BCL6 is the marker for endometriosis, and that's tested in the test called Receptiva, which is the non-invasive test for endometriosis. And if that comes back as a positive, then we treat you with suppressive medication such as the Orilissa we were talking about a few minutes ago for 60 days. If the CD138 marker comes back positive, CD138 is the marker for chronic endometritis. Endometritis, unlike endometriosis, is a chronic inflammation in the lining of the uterus. And the pathologist can tell that because they often will look and see a particular type of immune cell that's called a plasma cell. Plasma cells are the marker for endometritis, and CD138 is the marker for plasma cells. So if that test comes back positive, it means typically we'll treat you with 14 days of an antibiotic. So CD138 means 60 days of suppression for endometriosis. BCL6 is 60 days of suppression for endometriosis. CD138 is 14 days of suppression for endometritis. All right. Nurtured Shanna is here. Haven't seen you for a while. Brittany, looks like Brittany Lynn, 97, going through my 4th chemical pregnancy. Oh, gosh. I am so sorry to hear that, Brittany. 2nd, after my septum was removed. A septum is a muscular band that's inside the uterine cavity that can often cause problems with embryos implanting. Usually it's a band that runs down the middle of often in the middle of the uterine cavity. Fairly straightforward thing for us to remove surgically through a hysteroscope in the uterine cavity. That's a vaginal surgery. My estradiol dropped midway from 133 to 77 at the day of beta. Is estrase something I should advocate for? No, it is not. So estrogen levels, Brittany, are really not important in an ongoing pregnancy. The most important thing that we want to know is that your estrogen was sufficient to cause your lining to be thick enough at the time of starting your progesterone, or at the time that you're ovulating if you're doing a natural cycle. Thereafter, once that level is where it needs to be in order to get that lining thick enough, and that's the only thing that really matters, how thick the lining is. The number is not important. At CNY, we test that number because there is a public pressure to do so, but there is no evidence that supporting a serum level of estrogen has any importance to an ongoing pregnancy. Now, in natural cycles, when folks do letrozole, let's say a modified natural with some ovulation induction, letrozole lowers the estrogen level. And so sometimes we'll do this modified natural and we'll find that the estrogen level gets low. Somebody calls you and says, oh, your estrogen level is low. And now you think, oh my God, something is wrong with me. One more stressor in this whole damn process, when really, no, it's the letrozole made your estrogen level low. That's expected. So, Brittany, I would not worry so much about the estrogen level. That's not what's important. All right. The beta is what we're looking for. We want to see that number. In theory, 2/3 of them will double every 48 hours. That's really what we're looking for. Now, we also look at your progesterone level because that we will treat. The progesterone is the most important number, really next to the beta HCG. Let's see what else we have here on the CNY side. How many days before FET can we do intralipids? So intralipids is an IV infusion of it's a fat infusion, basically. What does it treat? Well, it's kind of an IV infusion of the keto diet. And what else does it do? It's actually very, very good for treating problems with a particular immune type issue known as natural killer cells. Usually we do that anywhere from 1 to 3 or so days before embryo transfer, although it can also be done on the day of transfer. So that's kind of how that works there. After implantation, can endometriosis stop a pregnancy from carrying on forward? Typically not. Typically, endometriosis is going to stand in the way of pregnancy implanting, but will not block an ongoing pregnancy. A little hello to Melanie Madrid and Melissa Marion there. Allison Rittenauer. The Miss Cole says, is it common to have a delayed second period after egg retrieval? Will taking medication to bring on a period for my FET cycle hinder anything in any way? Well, so, if you've done an egg retrieval, then what happens is that you release an egg and you create in the ovary a corpus luteum, and that is what secretes progesterone. So that progesterone, when the level drops off, will trigger the period. And I had a conversation with someone just this morning talking about what when am I going to get my period? On average, it's about 10 days. Sometimes it can take 14 or 15 days, but as long as you grew a lining, then that lining will slough off in a predictable fashion after an egg retrieval. So, Ms. Cole, I do think that you will get your period. Sometimes it may take just a little bit longer there. Let's see. Alicia says, Dr. Fink, after 5 transfers, I finally had my successful transfer in August. That is outstanding. We love to hear that. And I am 9 weeks pregnant now with twins. All right. But I'm nervous about stopping Prograf as I feel the higher dose is what finally got me here. How about some reassurance? Okay, let's talk about Prograf because, and we have talked about this before, I think it's a very important thing. And I really want everybody who is on board here today to know it. Prograf or tacrolimus is a medication that is used now to treat recurrent implantation failure. Prograf was studied in the group of people who were having, it's a medication that's used in organ transplant. So it's not uncommon that women of reproductive age have things like kidney transplants. Well, folks who have to have kidney transplants aren't always the healthiest of people, and so it is expected that after a kidney transplant, especially taking all these other medications and things, that you may find that their pregnancy outcomes are not as strong. Well, they looked at it and they found that there was one group of these kidney transplant patients who had exceptionally high ongoing pregnancies and low risk of pregnancy problems. And that was the folks who were taking the tacrolimus medication. So they went to study it for people who were having problems getting pregnant, that they keep putting embryos in and the embryos aren't sticking. And what they learned was that there are 2 types of immune cells. These are called T helper cells, type 1 and type 2. The T helper type 1 cell is the one that sounds all the alarms, rings all the buzzers, and says, oh my God, immune system, we've got to do something. Something is happening here. We need help. So it's looking at your pregnancy and saying, you're an invader. We have to come on out, my friends. Let's get involved here. We got to turn everything on, crank up the response. That's what the type 1 cell does. The type 2 cell is the one that says, hey, man, take it easy. Everything is cool. We can make some antibodies. We know how to do this. It's all good, baby. Just take it easy here. Well, we need both type 1 T helper cells and type 2 cells. But when people are rejecting a solid organ, like a kidney transplant, it's the type 1 cells that are overreacting. We need more activity from the type 2 cells, and that's what tacrolimus does. So when the body may be reacting against the pregnancy like it is a foreign invader, we need those cells that say, hey, whoa, dude, take it easy, man. We know how to do this here. Not the type 1 cells that are ringing the alarm bells. That's what tacrolimus does. Now, that problem is really likely something that happens, for the most part, in the first trimester, really closely around the time of implantation. They looked at it and said, well, what about, ongoing pregnancy outcomes? There are some folks who have poor pregnancy outcomes. Bad things happen to them in their pregnancies. Rupture of membranes at 16 weeks, infection at 19 weeks, these kinds of things. If you've had such an event, then there may be a good argument to stay on tacrolimus. However, in the absence of those things, there is no evidence that staying on it should continue to be helpful, because that T1 versus T2 fight happens at the level of the endometrium in the first trimester, mostly then at the time of implantation. Now, there are folks with recurrent pregnancy loss who may have some of the same problem, but again, that's a first trimester kind of problem unless proven otherwise. So I think that, Alicia, you can feel pretty confident that stopping it by 12 weeks will do the trick. And I'm so glad that is the case with you, that you've got these twins. Things are moving along. It's a wonderful, wonderful story. So incidentally, we have, so here in Colorado, I have recommended that every one of our patients beyond the tacrolimus for that reason, because I would much rather I would much rather prevent you from having that problem than find you have that problem X number of transfers later and have to treat it. And we have found that our ongoing pregnancy rate is, in fact, a little higher. So I think you can feel very good with that medication. So congratulations. Brooke Adcock says, you did my retrieval about a month ago, suppressing endometriosis right now with Orilissa until early November. We ended up with 5 embryos and we did not test them. I'm 32, hoping that means I have a good chance that some are normal and will work out. So, Brooke, in that scenario, 40% probability that each of those blasts will get you a pregnancy. So I would say that those odds are pretty good, especially because you're suppressing that endometriosis. Now it seems like you're doing all the right stuff here. So I would be very optimistic about that situation. Muriel says, I'm with CNY and 45 with low ovarian reserve. Do I continue with Omnitrope and naltrexone now that my follicles are non-existent after priming? Should I discontinue or cancel? My AMH was 0.2. So it is a low AMH. The Omnitrope and naltrexone are both priming mechanisms and really are trying to contribute to your egg quality there, Muriel. So what I would say is I think that you are when we do an ultrasound and we see what we call an antral follicle, that is follicles in the ovary, those are not follicles that I'm expecting. Those are going to be the ones necessarily that grow. So if you don't have any, it means you're not going to get any. Or if you have 5, then it means you're going to get 5 follicles that produce eggs. I would say it's not an unreasonable thing to say, well, let's try some gonadotropin for a few days and see. So if we do 5 days of gonadotropin and you have no follicular growth, then that may not be a good sign. But just because you're not seeing follicles right now doesn't mean that they won't be there once you start stimulation. Let's see. Sharmila asks, after FET transfer, can I fly or should we opt for roadways? Either one is fine. There is no prohibition against traveling. There is nothing about being in an airplane that is associated with failure to implant or any other such problem. Some people do prefer to drive, but either way, whatever you are comfortable with. Hey, it's 32 minutes past the hour. We've been here for about a half an hour. Be here for about another half an hour. This is Fertility with Fink and Friends. I am Fink. You are Friends. And as always, every Tuesday, it is great to be with you. Special hello to my mom and dad if they are watching. I didn't see them sign in, but sometimes they try to fool me on that. A special hello to Brandis and a special hello to Noodles for Life, who asked the next question. Here, my estrogen before medicated FET is close to 2,000. Today at transfer, it's about 200. Is that normal for it to decrease, especially after progesterone is introduced? Yeah, it can. And again, the estrogen level really doesn't matter. So I wish that we didn't even test it, because all it does is create angst and anxiety with people. The most important thing about your estrogen is, did it make your lining thick enough to allow for your progesterone start? The lining will then start. People often ask this too: why don't you test the lining? Why don't you do measure my lining on the day of my embryo transfer? And the answer to that is that, well, it compacts. Once you start the progesterone, that lining starts to compact. It gets tighter. And so what it looks like at the time of transfer is not as important as when does it start to compact. And that would be when it's thick enough, and that's the time of progesterone start. So 6.5 days of progesterone, or typically 120 hours is what we're after of progesterone timing, and that makes for a perfectly ripe endometrium to put your embryo in. When coming off Orilissa, Shanna asks, is it a medicated or a modified natural transfer better? So when you've been on suppression, you are turning down the volume knob of the hormones in the brain, in the pituitary. And so sometimes it is a little slow to start. Sometimes it may not want to. Your brain may be a little sluggish in terms of the way it makes your hormones. And so I would think from a purist standpoint, doing a medicated cycle is going to be a little easier because it doesn't matter what your brain is going to be or your pituitary gland is going to be doing. We're going to control the hormones. However, a modified natural is not a problem. We can do that, but sometimes it may take a couple of rounds of letrozole in order to get you to produce the follicle that's going to be making the hormones. So I certainly think the more direct way to do it, the easier way to do that is with a medicated cycle. But can you do it with a modified natural? Yes. Yes, Shana, you can. Let's see here on the CNY side, which brace face tiara, which office are you located? I am in Colorado Springs. So CNY has Colorado Springs. We have Syracuse, Buffalo, and Albany for our New York locations that do full service IVF. And we have Sarasota, Florida. We also have monitoring centers, which just do outpatient monitoring in Rochester, in the Philadelphia area, in Atlanta. And let's see, we're opening one, in fact, in Denver, and hopefully there'll be one coming near you. But the whole goal with this process is for you to be able to monitor at home and spend as much time as at home as possible and still just have to come to one of our facilities for your retrieval and or your transfer. How much time should you plan to spend at our facility? Well, like I said last week, we heard a couple of little horror stories last week of people who got delayed when they were trying to travel. I really want you to get to our facility the day before. Plan your flight, plan your drive, plan your trip to get here at least the day before if you're going to be doing an egg retrieval, because doing that the morning of is enough to make your hair turn gray. It's enough to really cause a lot of stress. And so, unfortunately, I think travel now, unless you're flying by private jet, air travel is not reliable enough in this day and age to get you where you need to be, in a real predictable fashion. If you've got a deadline, sort of like, well, if you're going to your sister's wedding and it's on Saturday at noon, you don't want to be flying on Saturday morning to try to get there, because there's a good probability that something's going to happen. There's going to be a weather problem, an air traffic problem, a crew problem, a flat tire, you name it. Screw's going to come out. Even if you're driving in that scenario, there's going to be an accident on the highway, or you're going to blow a gasket or run out of gas, or something's going to happen. You don't want to cut it that close. So get here the day before, and you'll be a much happier person for it. And the same thing goes for embryo transfer. Get here the day before. There's often some things that we try to do the day before embryo transfer, things like some washes or some lipid infusions, and you can do all that stuff in our facility the day before. Get a good night's sleep. If you're doing your transfer, you can go home that evening if you want to, but don't plan your trip that afternoon, because the same thing, you never know what's going to happen. If things are going to get delayed in the office, or there's a problem with getting an embryo thawed, or you name it, if you want to travel that evening, I think that's completely safe. Plus, you know what? Just slow down, take a little time, enjoy the ride, because as long as you're getting a change of scenery, it's nice to enjoy a little bit of that scenery without having to be someplace so fast. By the way, if you recall last week, we talked a little bit about that sign behind me there. And the first word on it is kindness. I believe that the world is not a kind enough place, and the little kinds of things that we can do for people, such as simply smiling at a stranger, helping someone who is lost, just stopping a kind word to someone who you might not otherwise pay a lot of attention to. These things make a huge difference in the world. And I think our world could use a change like that. We talked about that last week, and I got a few nice emails, some correspondences from people who wanted to tell me about some of the nice things that they did. And some of them are really pretty simple stuff. And it's not always necessarily doing something nice for somebody else. It may also be just doing something nice for yourself. Stopping to pet a dog, stopping to pet a cat that's out on the street. It just makes you feel good, to see an animal and to interact with an animal. As long as it doesn't bite you, then or scratch you, then that's a nice thing. Being nice to a child, and I had cause to think about this because one of our medical assistants here at the CNY office had her little boy with her on Saturday when I was at work, and he was absolutely a beautiful child, just a precious little thing. He looked like he's probably maybe three or four or so. Really beautiful child, and it's just instinctive that we're nice to children. And so I started talking to him. We talked about Mickey Mouse on his shirt, and we had a little conversation about him being here at work. And it made me feel good to talk to a child. And again, it's instinctive that we do that. Why is it that at some point we stop being nice to each other? That then you start to get aggressive with people. You go into a store and someone doesn't make you happy behind the counter, and so you get really nasty with them. People push our buttons, or we get road rage and we scream at someone who cuts us off, or someone cuts us off. I mean, why do they need to do that? At some point, it changes from being so nice like we are to kids or to somebody's pet, and then at some point it changes. So be mindful of those things. Be mindful of how you interact with people, because the world really could use every step forward with kindness. Because think about the changes we could make if everybody was just nice to everybody else. And one little kind word, one little random act of kindness may be enough to really change the place we're living. So that was my moral soapbox for the day. And thanks for engaging me there. Ruzik Blue in Las Vegas says, I've done 6 unsuccessful transfers, tried and tested everything except for ERA, Emma, and Alice. Would you recommend anything else? So when folks have had recurrent implantation failure, the usual workup I recommend is, number 1, hysteroscopy. We want to know that the uterine cavity, that the uterine lining is normal, that there's no polyps, that there's no septum, bands of muscle, balls of muscle like a fibroid, that there's no scar tissue on the inside, or anything that is going to prevent your embryo mechanically from implanting. I always recommend in that scenario that we do a biopsy so that somebody can look at that under the microscope and make sure that we don't have chronic endometritis or chronic inflammation in that lining. We used to always say laparoscopy. You need hysteroscopy and laparoscopy. Why do you do a laparoscopy? It's to make sure that you don't have endometriosis. Do you have to do a laparoscopy? Well, now we can do that non-invasively with a very high specificity. About 95% is the sensitivity and specificity of the Receptiva test. So through an endometrial biopsy, we can see if endometriosis can be causing your recurrent implantation failure. We want to know that. So I'd say that's a very important thing. I would want to make sure that you're on the correct dose of Prograf, like we talked about. So the Prograf we used to use at a dose of 0.5 milligrams twice a day. But now from the study that originally came out in, I think it was March or April, we've learned that really 3 milligrams a day is the correct dose. So that's either 1.5 milligrams twice daily, or 1 milligram 3 times a day is probably an easier way to do that. So I'd want to make sure that you're on the correct doses. The ERA has really not been shown to be a meaningful test. Now, if you've done all the other stuff, and we have no other reason, we can't figure out why your pregnancies aren't implanting, then maybe an ERA might make sense. The ERA is an endometrial receptivity assay. And what that means is that you do a mock medicated cycle. You do a regular standard medicated cycle like you were going to be putting an embryo in. But rather than putting an embryo in, we suck a little piece of tissue out. And we can measure the time at which your body is looking for an implantation. And that sounds really good, right? That sounds like, oh man, yeah, why wouldn't everybody should be doing that? Well, that used to be a standard part of our evaluation, that everybody would have that when things weren't working. But big studies that came out looking at tens of thousands of cycles found that the ERA doesn't make a difference in pregnancy outcomes. It doesn't mean there are not more live births, there are not more positive pregnancy tests with the ERA. So as such, it is not a test that we routinely recommend anymore. It's a last resort. So Ruzik, if you've done all the other stuff, then maybe it's something to consider, but I would strongly advise you talk to one of us so that we can kind of look through your chart and let's figure out, is there something that's missing here that we can do to get your sticky embryos to stick better? Let's see. Oh gosh, Sharmila says, you are the world's best doctor I have ever met, and thank you for your treatment, Sharmila, and you are the smartest person I know. Clearly, absolutely. Shanna says, is metformin recommended in preparation for FET? So particularly in folks who have polycystic ovarian syndrome, metformin can decrease the risk of miscarriage in an embryo transfer cycle. So in many cases, I will say yes. I'd like you to still be on metformin. Is it necessary in the months preceding it? No, not necessarily. Let's see. Amanda says, hi, Dr. Fink, about to start transferring in the next month or so. Do you recommend starting with modified, natural, or medicated? As we talked about, it's really a choice of yours. If you have regular cycles, I think a modified natural is really is an easier way on your body to go. And that's what I would recommend for you. Not knowing who you are, not knowing anything else about your cycles, I would say, that's a good place to start. But either way, the outcomes should be equivalent and has to do with what's going to be easier on your body. Let's see here. Monkey Mo, do you recommend resveratrol for egg retrieval? So resveratrol is a type of antioxidant. And it hasn't been really well studied. So is it going to harm anything? No, but there is an evidence-based list of supplements that I recommend for embryo transfer. You can find that. In fact, I wrote a book about it. You can find that list it's an ebook called The Vitamin Victory on my link tree, and that's linktr.ee/Randy Fink MD. Or if you forget that, go to my Instagram, which is Randy Fink MD, and it is the link that's in the bio. Click on that link. You'll see the list, or rather, you'll see the link for that ebook. $7 gets you the ebook, and that will get you a discount code that will save you about $25 or $30 or so on all the supplements on the list. There is an evidence-based protocol for regular old egg quality, for whether you are doing home timed intercourse at home, whether you're doing IUIs or IVF. There is a separate protocol for folks with diminished ovarian reserve. The regular protocol has 7 things on it. The diminished ovarian reserve protocol has 10 things on it. There is a protocol for embryo transfer that has 5 things on it. And there's also a protocol for there's a protocol for PCOS, some exceptions for PCOS and endometriosis, as well as a protocol for sperm quality. So that is all evidence-based. I believe to the extent we are able, we should follow the trail of the evidence, because the studies will show us really what we want to know. And so that's why I created that source, Linktree Randy Fink MD, or just look at my Instagram for the link in the bio. How soon can you transfer after having fibroids removed? That comes from Sarah Beth. Well, it depends on what we're talking about. So if you have had a fibroid that was in the uterine cavity and you did a hysteroscopy, a camera inside the uterus to remove that fibroid, I would say at least a month. If, however, you had a surgery where the fibroids were part of the uterine wall, and you either did an open surgery or a laparoscopic surgery to remove those fibroids, I would say that may take at least 2 to 3 months to heal. And depending on how aggressive that was, maybe even up to 6 months. So I would recommend that you talk to your surgeon, who can tell you kind of exactly what happened to that uterine muscle and what you need to do to let it heal. Back over to the Facebook side, Lindsay Stang says, almost 15 weeks pregnant, can't be happier with my experience at the Colorado Clinic. You guys are seriously amazing. Lindsay, that is such one. We live for that. Thank you very much. So thankful for you and the Colorado Clinic. Sincerely, thank you very, very much. Carolina says, I just did my egg retrieval on Friday. I have 3 embryos. What's the next step? Do I wait for my period this month, if October, or wait for November? Well, so if you've got embryos, so it sounds like you did a retrieval, you made some embryos, and now you're waiting to see what happens next. Well, when you get your period, you can absolutely proceed with an embryo transfer cycle. You do not need to wait. It is really whenever you are ready, then you are good to begin. Now, for folks who are doing IVF, I do recommend back-to-back cycles. And that is to say, the more cycles that you can stack on top of each other, you get typically progressively better results. In theory, that should be what happens. When it comes to embryo transfer, doesn't matter whether you do them back to back, even if it doesn't work, you can go right into the next transfer cycle, or you can wait. So you kind of have to be emotionally ready, you have to be financially ready, you have to be physically ready. But as long as those things are good there, my friend, you can go on to your transfer cycle. Next, let us know when you get your period. And the period's typically 10 to 14 days after you do your egg retrieval. Rachel says, my last transfer ended with an empty gestational sac. I had a D&C on the 30th of August. Rachel, sorry to hear about that. Just had my HCG tech for the first time 4 weeks later, and it's 8:04. That's interesting. 4 weeks later, from an empty sac, I would expect for that to have been negative. Retested 6 days later, and it's 5:27. That would certainly make me concerned for either, so first of all, I'd want to know for sure that pregnancy was inside the uterine cavity. How would we know that for sure? The sac was in there. Well, they did a D&C, so they got some tissue out, and they would look at that, and it would say chorionic villi were present. Chorionic villi are the pathologic under the microscope feature that shows us that is where the pregnancy was. So therefore, you're going to make sure that, it wasn't incidentally a pregnancy that was in the fallopian tube, and that kind of got missed there. But any OBGYN would know that they want to look and see villi from the specimen. And if not, they should have cause to go looking elsewhere. Sometimes it can be that it takes a little time for the HCG to kind of keep going down. They have studied and haven't really come up with meaningful answers on how long should it necessarily take. I would tell you, Rachel, that if it's a month later and that HCG is 8:04, especially if you weren't, much further along in pregnancy, it does give me some concern that there could still be some pregnancy tissue on the inside. So I want to know where the next level is, and you certainly want to follow that level now down to 0. You want to make sure that your beta does, in fact, end up negative. Let's see. We've got a little less than 10 minutes here. So McRae Hines says thoughts on a retroverted uterus. Yes, indeed. Some people are right-handed. Some people are left-handed. Some uteruses sit forward. Some uteruses sit backwards. Some are in the mid position. And notice my wrist there. So if you're lying down, if we're going to be doing a pelvic examination so that I'm going to feel your uterus, if you're lying down, sometimes the uterus sits, well, let's see. If my arm is here, let me stand up here. If my arm is here, that's a uterus that sits forward. That's a mid-position uterus. That's a uterus that sits backward. The backward sitting uterus is called retroverted. It is not associated with pregnancy, with difficulty getting pregnant. Now, sometimes people can have what's called a retroflexed uterus, and I can't do it with my own hand, but it's where the uterus goes in, it goes down, and then it curves under itself. Those can be difficult sometimes to get a catheter in to do an embryo transfer, but that's what we do for a living. So we're pretty accustomed to being able to get that done. A retroverted uterus in some people may mean that when you get cramps, you feel them more in your lower back. It may mean that you may have more pain kind of in the rectum area when you get crampy. But other than that, a retroverted uterus is a variant, just like being right-handed or left-handed. So it is not a handicap. Cherry Shore says, hi, Dr. Fink. What determines if you need more than 120 hours of progesterone before an FET? Well, so that would be the ERA test that we talked about, the endometrial receptivity assay, which again, no longer really recommended because what we've learned is that the body tends to compensate. The body tends to compensate for those differences, especially if we do a natural cycle, then we don't have to be as rigorous about that timing because we can't say really precisely what time ovulation is going to occur. But the body compensates for that. There is some evidence that shows also that when people are not normal in their timing, that sometimes if we just extend that by about 10 hours, we may be able to get a better outcome. That is something that's currently being studied, but usually 120 hours plus or minus 3, and that would otherwise be determined by an ERA. Alyssa Marie says active cysts, even with Lupron. You give it some time, those cysts will typically resolve. And back over here on the CNY side. All right. Al Doris says, I had 2 pregnancy losses, and both I was able to conceive after the second try. We've been trying for 6 months and nothing. I'm 36. My husband is 45. Everything came out normal with the labs. Well, I'd be curious to know a little bit more about the losses, how far along they happen. But sometimes people have what's known as unexplained infertility. And that's really just an issue of getting the right sperm together with the right egg at the right time. And that's often what we try to do. We can really just help you with timing there, Aldoris. But unexplained infertility is a real thing. What does it mean? It means, well, when everything else looks normal, but for some reason, pregnancy doesn't take place. Now, there are often some things that may be at play there with unexplained infertility. Sometimes there may be a sperm fragmentation issue that you can't see by looking at the sperm count or one of the indices in a normal semen analysis. Sometimes there may be an autoimmune issue at the level of the endometrium, or there may be previously unrecognized endometriosis. These are some of the more common things, and they are certainly things that we can help you to look at. Chris Stillbore says, good evening. Glad to see you. My pleasure. I'm on my supplements from your book. for a December retrieval, hoping for better results. Well, yes, indeed. Fingers are crossed, my friend, for sure. I have to say, I think that October is a great month to sort of be involved in the fertility process because there's just something magical about, Halloween and autumn and the leaves changing. And also, it is my birthday month. My birthday is this Friday, October the 4th, 10-4, good buddy. And so if I can be born in October, then it must be a lucky month for everybody. That is my only logical conclusion. So I want to say a very special best wishes to every single one of you out there, no matter what you are doing this month. If you are waiting, if you are treating, if you are doing a retrieval or a transfer or doing an IUI or not even trying to get pregnant, maybe you're going to buy a lottery ticket. Maybe something's going to happen at work that is going to be a surprise in your favor. The very, very best for everything life has to offer for you this month of October in honor of my birthday. So, my friends, that is all the time we have for tonight. Until next week, thank you so much for being here. As always, on every Tuesday, I am Fink, and you are friends. You are my friends. Every step forward with kindness and with love and with hope for a new beginning tomorrow. The sun goes down today and the sun rises tomorrow. It's a new day, and it is full of all kinds of new possibilities. This fertility business is not the book of your life. It is but a chapter. And what are we doing? We are here to rewrite it together. Thank you so much. See you next week. Good night.